Hello, and welcome to MDIC's annual public forum. During today's session, you will hear an update on MDIC's Case for Quality program as a collaborative community, as well as with updates on the Voluntary Improvement Program and initiation of the Medical Device Information Analysis and Sharing Program, with a discussion led by MDIC Case for Quality Program Director Alan Baumel. Please make sure to join in the conversation on Twitter by following at MDIC Annual Forum and using the hashtag MDICAPF2020. Now, please welcome session moderator Alan Baumel.
Good afternoon, everyone. It's a pleasure to welcome you to today's installation of the MDIC Annual Public Forum. Today's forum focuses on the Case for Quality as a collaborative community, the Voluntary Improvement Program, and the Medical Device Information Analysis and Sharing Initiative, referred to as MDIAS. I'm excited to introduce a wonderful panel that we have today featuring representatives from industry and the FDA. On the panel, we have Joe Sapiente. Joe is Vice President of Quality Assurance and Regulatory Affairs, Surgical Breast, Skeletal Health, and Medical Aesthetics for Hologic. Joe is the chair of the Case for Quality Steering Committee and has been an active member of the Case for Quality since 2012. We also have Cisco Vicenty. Cisco is the program manager for the Case for Quality within the Office of Compliance, Center for Devices and Radiological Health at the FDA, and member of the Case for Quality Steering Committee. We have Rob Becker. Rob is head of quality for Edwards Lifesciences facility in Draper, Utah, which is one of the early participants in Case for Quality Voluntary Improvement Pilot and the Make Kappa Cool pilot study. We also have Kim Kaplan. Kim is a program manager at ISACA and has been a collaborator on VIP since the development of the pilot in early 2017. Kim is also now an advisor on the VIP Governing Committee. We also have Dr. Mike Ruhlen. Dr. Ruhlen is Vice President, Medical Education, Atrium Health in Charlotte, North Carolina. He has been engaged with CFQ since 2016 and is co-chair of the MDIAS Governance Working Group and a member of the MDIAS Use Case Working Group. We have Mike McCarthy. Mike is a senior principal engineer for Baxter Global Quality Operations and Strategy Team based in Northern Illinois, specializing in risk management and production and process control. And lastly, we have Al Crouse. Al is the Senior Director of Quality Assurance and Quality Systems at CVRx in Minneapolis, which has participated in pre-pilot and pilot assessments for the Case for Quality VIP program, as well as the FDA Critical to Quality Inspection Program. This is an esteemed group that we have today. My name is Alan Baumel, MDIC's Case for Quality Program Director and moderator for today's panel. I'm now pleased to introduce our next presenter, Joe Sapiente.
Thank you, Alan. Appreciate it. First of all, I'd like to thank MDIC for giving me the opportunity to be a part of the Case for Quality. Also, to be able to work with such a collaborative, talented, and professional group, this cross-functional team within the Case for Quality, and also to address this much larger and broader audience today. So the collaborative community is addressing public health issues, and when we first launched the Case for Quality, the initiative was launched to reduce the risk to patients around the world from quality issues, as well as gaps that we found within manufacturing and within innovation and product design practices. The Case for Quality was founded for these reasons. It was based off of the complexities of the medical device ecosystem, and it required a lot of broad participation and engagement from the stakeholders. And we'll see shortly the number of stakeholders that are involved in the Case for Quality and how that continues to grow. But this environment has been collaborative from the very beginning, with the idea of having identified opportunities to shape, transform, and really lead the efforts to advance regulatory science. So a little bit of the history of the case for quality. I'll take you through a couple of milestone dates for the case for quality, starting with 2015, when the case for quality stakeholder engagement forums were initiated through the BAA process. These forums have been a real source of collaborative and an engagement from a variety of stakeholders. Within each of these forums, we've been able to identify a lot of key challenges and opportunities that are shared across the industry, as well as our key stakeholders, all geared towards moving and shifting our conversations away from compliance and into quality, and then looking at those and identifying those areas of opportunity, whether it's something like the maturity model, analytics, metrics, compliance, and as well as competencies. In 2016, we formed the Case for Quality Steering Committee. That group continues to drive the strategies within the Case for Quality and works very collaboratively with our stakeholders through these forums, through strategic sessions to help identify opportunities within the Case for Quality, again, supporting our vision and mission within the Case for Quality. In 2017, and you will hear more about the Voluntary Improvement Program, but in 2017, we launched the Voluntary Improvement Program, which was that pilot program of the appraisal process. Since then, we've had a number of very positive outcomes from those assessments or those appraisals, and we're now moving towards operationalization of that program, bringing it to a full program in itself, which then leads me to the 2019 charter and ratifying of the CFQ VIP Governance Committee, which is the committee that will take that VIP pilot into a VIP fully implemented program. Now in 2020, we're talking about the collaborative community. And when you think about where we are headed, the CFQ committee has really been operating as a collaborative community for quite some time. And it really, this transition really does make a lot of sense for us. And we're really excited about the opportunity to take this into the next phase of Case for Quality. So the purpose of the collaborative community, as we talked about, was taking those forums and really taking the opportunity from the forums and that group of engaged individuals from across the industry and our stakeholder group to really drive to those and identify challenges and opportunities, to then accelerate the opportunities within the development of the science-based solutions, and then ultimately getting to a point where we have those collaborative communities reaching those consensus-oriented solutions, and then implementing those solutions. And things that you'll see today are really an output of the forums that we've hosted and participated in over the years to get us to this point. So participation in the collaborative community, what does that really look like? So each member of the collaborative community and of the Case for Quality really is a highly engaged member of the ecosystem. The idea here is that every member participates and helps drive and adopt those solutions that the collaborative community reaches those consensus in. Here's an example where CDRH is an active member of the collaborative community. They are not there to lead or establish the collaborative community or operate the collaborative community, but they are an active member with a seat at the table across the table from other members and other stakeholder groups. But clearly, the CDRH has laid the groundwork for several other collaborative communities, and those of you who may have been involved or may be involved in NEST, which is the National Evaluation System for Health Technology. That collaborative community has been established for some time, as well as has helped create the foundation for the other collaborative communities, and certainly our Case for Quality collaborative community. Here I wanted to point out a few things within this diagram. What you can see here is pretty much the history of Case for Quality as we started out as a group with identified stakeholders. And here, the three main stakeholders in the very beginning of Case for Quality was FDA, industry, and those payers, providers, patients, and academia. And now, with the collaborative community, we really expanded that ecosystem to include the VIP, or the Voluntary Improvement Program, the Medical Device Information Analysis and Sharing, or MDIAS, the partnership with MITRE, the partnership and the work that's being done through the appraisal process or the appraisal method under CMMI, the regulatory research within MDIC, all geared again towards that initial vision and mission of reducing patient risks and addressing opportunities within manufacturing and design process to help drive innovation and to help shape and influence the future of medical devices and product safety and quality. So the structure of the collaborative community is based off of really the MDIC Foundation, which is a public-private collaboration based on the shared challenges that I mentioned earlier. Within the case for quality, which has been a basic foundation of the case for quality, it's really been that trust and respect and openness. Without that trust, respect, and openness, we would not be where we are today. The accountability and responsibility really is something that each of the work streams and the members of the case for quality, whether you're a steering committee member or a work stream participant, really takes that role and that responsibility very seriously. We've developed best practices and strategies using the collective resources and expertise. We've had companies volunteer resources to work almost full time on some of these initiatives. And without that support, again, we would not be as successful as we have been. Within the collaborative community, the role of MDIC is not going to be the overseer, but they will be the convener of the case of the community. That'll give us the opportunity to really have them operate the way they've been operating for us within the case for quality today, providing us that ability to access to forums, creating that neutral space or that safe space in order for folks to collaborate within the world of that trust and respect and openness, and help coordinate and facilitate the sustainability of the case for quality. And that's really something that's very key for us, because as we move to a collaborative community, the case for quality now becomes a much more sustainable program. Not that it wasn't before, but certainly it will have the staying power that we've been looking for from the very beginning. So again, as the case for quality is originally established to operate as a collaborative community, we've been operating really that way from the very beginning. And again, not to overemphasize it, but we would not be here where we are today had it not been for our ability to collaborate very early and to be that trust and respect and openness with each other. So within the transformation of the structure and the reorganize the case for quality as a community, I want to spend a little bit of time just talking about what that structure looks like and what that transformation has really addressed going forward. So here is in this diagram, a little bit different than the previous diagram, but a lot of the same participants and stakeholders that you saw in the previous diagram, where you've got MDIC as the case for quality community convener. You have the steering committee or the case for quality steering committee under the collaborative community. You then see some familiar work streams, which are the Make Kappa Cool, the quality as a career, the C-suite leadership, and data and analytics. We expect that under the strategic planning and mission and vision of the steering committee, those work streams will continue, and some will be sunsetted. As an example of a work stream that continued and really took and matured over the years is the VIP program, which was originally the maturity model, which was one of the original 4 work streams. And you can see here that it is now one of the major contributors to the collaborative community, as well as MDIAS, and that governing committee is now taking shape as well as part of the overall collaborative community. And then you see the safe space, which is something that we launched as well, which will also become a major contributor to the case for quality collaborative community. Next slide, please. So within, I just want to close and say that as we've founded the vision and mission of the case for quality to reduce risks to patients, the transformation of the case for quality from a ecosystem program to a collaborative community really is an exciting opportunity for us. And again, one of the key areas for that collaborative community is the VIP program. And with that, I'd like to introduce Rob Becker from Edwards Lifesciences and Kim Kaplan of ISACA to take us through the VIP program. Rob, Kim?
Thanks, Joe. Today, Rob and I are going to be talking about the Voluntary Improvement Program. I'm sure many of you who are following this program are wondering about the impact of COVID-19. And I'll say that we learned very quickly in April that we needed to put a hold on our on-site activities and start considering what a virtual approach might look like. So we spent some time designing and developing a pilot approach to a virtual appraisal, and we were able to complete 2 pilots in May and June, collecting lessons learned as we went and continuing to update our guidelines. Here you can see some of the outcomes of those 2 pilots, which you can see were pretty positive. We were able to maintain a low burden of time commitment. We were able to train the majority of participants sufficiently for the remote activities that were expected of them. The majority of participants believed that this was a comparable value add activity, and all of our stakeholders were satisfied to some degree with the approach. Based on what we learned, we believe that we are able to roll out this option to those sites that could most easily accommodate this approach. Those being organizations that are in their 3rd year or greater, have a single site, and are within 5 hours of their appraisal team. Now, of course, not every organization fits into that category, and so we're looking at how we can continue to pilot this for organizations that are only in their 2nd year, maybe have multiple facilities that are being considered in their appraisal, or are maybe internationally located or greater than 5-hour time zone from their team. Right now, we have 8 facilities that are in the process of considering what this virtual approach might look like on their site or at their site, and you can see that that is spread across these various categories. As for year 1 activities, this is for an organization that is just entering the program and still has a lot of learning to do. And so we're trying to figure out what is the best way to continue to keep these individuals engaged before we can come on site and complete an appraisal. I think all of our stakeholders have shared the same concerns that the 1st year is really critical to showing organizations how this approach is different from an audit or an inspection. And so we're in the midst of those discussions now, and we're hoping to have something that we could potentially pilot sometime by mid-September. So this COVID-19 delay has definitely impacted some of our success metrics. A lot of them we haven't been able to update because not much has happened since March. But we do have a couple of updates that I'm happy to share with all of you here. As you can see, over time, cumulatively, program adoption and program or participant involvement has continued to grow. You can see how that's grown over the years and where we are today. I do want to note that we are not comparing apples to apples because each of these points represents a complete year, except for the last point, 2020, represents only a part year. So that's part of the reason for the decline in addition to COVID-19. But I will say we expect the bulk of our appraisals this year to be happening in this 3rd and 4th quarter. So we hope to see those numbers on the left side graph continue to increase. And as for the right side, in terms of our training and continuing to onboard new appraisers, we were able to complete 1 virtual training course so far this year, and we were planning to deliver 2 more, but due to demand, we now think we're going to have to offer 1 or more additional courses. So we're hoping to continue to train people and continue to onboard new appraisers, both internal and our own, into the program. Another key topic that I'm sure you're all wondering about is the transition of VIP from pilot to program. There are a couple of activities that we have continued to further in order to make that effort a reality. One being that the VIP Governing Committee has established its committee chair and began meeting this year. We are also restarting our working groups now formally under the VIP Governing Committee. We are defining the operationalization plan that is currently under development, and we anticipate having that delivered by the end of this calendar year. And as Joe mentioned, the establishment of this collaborative community, we're looking at how our governing committee and our charter can continue to align with that overall vision. And with that, I'll turn it over to my colleague, Rob Becker.
Thank you, Kim. I appreciate the opportunity to be able to present. So thank you to MDIC for the invitation. And as the initial site that completed the first appraisal within the VIP, we continue to be very excited about the opportunity that this represents. And really the best way for me to put that in context is it gives us a very balanced set of feedback that we can use as a site to make sure that we are looking at the site with an entirety of perspective. We still have our MDSAP audit, and obviously for any company within our space, maintaining a rigorous quality system, making sure that that quality system is being executed, and that we're honoring those responsibilities is extremely important. But the CMMI process and the MDDAP appraisal gives us a different set of feedback, and I like to characterize that as giving us the voice of the organization. You know, like many companies, we are a complex entity with a lot of moving pieces, a lot of different functions. And we find that having that different voice and a representation of some of those other aspects of our organization is extremely important for making us better. And both of these processes are positive because we're able to plan them in effectively. You know, nobody likes surprises, especially for an organization of any particular size. And the ability to understand, plan the calendar, make sure resources are available, and to get these inputs in a way that is minimally disruptive and also aligns with a format that lets us plan our strategic processing, realize where we need to get better is an extremely good combination. And so what I mean by that, when we look at our facility, you know, there are many, many different things that have to happen for us to be successful and to have high quality products going out to our physicians and ultimately to the patients that we're serving. A lot of that starts with the products and processes. Obviously, you know, our products need to be well designed. They need to meet their intended use. We also have a lot of detail in the processes used to manufacture, inspect, and make sure those products are fit for use. Our quality system is a pillar of our site. It provides a lot of the direction that we need for certain activities, CAPA and CR's internal audits, which are all very important for us maintaining both the compliance, but also some of the improvements and identifying where we have issues that need to be addressed. Site management is clearly important and plays an important part in all of the processes that you see here in terms of making sure the site is engaged, focused on the right priorities, has the right resources. And then people. Nothing happens at this facility without people, the engagement of those people, and the investment in those people. And so if we look at the traditional landscape prior to Case for Quality VIP, it was very focused on compliance, very focused on activities that would minimize your compliance risk. And the quality system tended to be very isolated and not part of necessarily integrating in with the rest of the site, other than focus on those compliance aspects and meeting our regulatory requirements. And so when we look at the broad ecosystem of the site and all the activities that are necessary to support, getting that additional feedback, the voice of the organization, which is how are we doing on site management and management's communication with employees? Are people feeling the investment they need? And how do people relate to the work that they're doing? You know, is our compliance so good that it's almost impossible for our teams to actually get work done? Or is there opportunity to balance between the two? And that additional feedback from the organization is what we get through the MDDP process and feedback. And what do I mean by that? I think that's probably the most common question that I get is, you know, okay, you're doing this appraisal process. You know, you say that the feedback is valuable for your site, but what does that really look like? And so what I thought I'd share is some of the summary of the results that we got from our last appraisal here at our site. And so the appraisal feedback we got really goes into categories. And I'd say the most important one is we have a quality management system. It's very well described. It has requirements, forms, processes, structure. And then there's the rest of the facility where business practices like budgeting, communication within the site, how teams are structured, tends to be very unstructured. And where the QMS and those business practices interact tends to be where a lot of conflict happens, and or where your organization is less efficient or less effective than it could be. We don't share a lot of lessons learned, or we don't share those very well. So we have a big site here. We have multiple teams. We see things happen, and as much as we try to, we don't always disseminate and have good forums for lessons learned. Evolving objectives, I think that's probably a familiar one for everyone. Things change throughout the year, throughout the week, and so priorities, focus for the site. Teams need to be able to be aligned quickly with those evolving objectives, and where your organization is not aligned with those, there tends to be conflict, inefficiency, and you're not performing as well as you need to. Data is another good source where we find that we can spend time to improve the effectiveness of our organization. I think everybody can relate to not having the right data to make a decision, the data not being timely, the data might be hard to get to. And so if we can focus on making data available, making data available to the right teams in the right places, and empower them to be aware of their surroundings, but also quicker to make decisions because they've got the right information, we will perform better as an organization. And then the other big one for us is task switching. The more tasks you have, or the more those tasks change over time, the less efficient and effective you are. So it's a question of change management. So as a site, how do we focus on change management? How do we communicate with teams when their tasking changes? How do we make sure if we prioritize something, we deprioritize something else? And how are we having those conversations? And so this is a lot of the feedback and what we work on as a result of participating in VIP. And these are the types of things that we feel if we can get better in these areas, we will continue to perform better as an organization. And then as a result, we'll have more time to focus on patient safety, product quality as a core of what we do. And then the last thing I wanted to address is we're approaching our 4th appraisal within VIP. And the biggest thing about it as we've gone through the years is that the approach is flexible. We as a site have the ability to influence or have input into what our next appraisal looks like. We work with our lead appraiser to do that. And that is tremendously valuable to us because, it's easy to get, have an event, have it on site. But when management has a chance and people within the site have a chance to influence that appraisal so that we get feedback that we actually want to have, then that's a powerful agent for us to continue to embrace and make change based on the feedback we get. And so year 1, we did the standard baseline appraisal, 11 practice areas, level 2. And, we took a look at that. Our second appraisal, we expanded that. We added 2 practice areas, but we also went to level 3. So in addition to getting the level 2 feedback, we got feedback at the next level within the process. And we added an additional practice area for OT. And then in year 3, we took all the practice areas to level 3, added additional practice areas for supplier management and risk. And then we did something called objective evidence and observation. So instead of just interview-based appraisal, we took a look at how we could make that better. And that included having the appraisers go to certain meetings within the site and observe the actual meetings happening, spending more time in the environment with some of our production team, actually being in their environment and observing some of their work, and also looking at some of the structure, records, documents, not to the same extent or type that you would during an appraisal, but really live of, hey, these are the documents we use, or this is the information we use for these certain processes. And we found that gave a more effective and comprehensive picture than what we got out of just the interview-based style. So it was a good next step for us. And then looking forward to year 4, we have some areas where we haven't gotten or our performance is good. PI and TS, those are pretty common that within the medical device industry, those are going to perform pretty well because those are really about production planning, process control, change management, change control. And so we're able to take those areas where we don't have any projects identified and we've performed well and not focus on those through this year's appraisal. So we're able to de-scope some of the areas that we have good feedback and we're not making improvements. At the same time, we've chosen to add areas that we think we can get additional feedback. So decision making and some of our project management, we're able to focus on those because those are areas we recognize that we can improve as a site, we can get better. And so putting a more concentrated effort on that provides value for us as we look forward to next year's opportunities for improvement. And with that, I'd like to introduce Dr. Mike Ruhlen, who's going to take us through the MDIAS.
Thank you, Rob. It's a real privilege to be associated with the MDIAS effort and initiative, and I very much appreciate the opportunity to speak at today's annual forum. I'd like to start by introducing you to my father. This is a photograph of Dad and my granddaughter, Anna, at his 60th wedding anniversary. My father was a cancer survivor, and at the end of his life, he had a traumatic episode that took him to the hospital. He was there overdosed with antibiotics, culminating in a bad Clostridium difficile infection, which then precipitated a hypovolemic shock, impairing both his heart and his kidneys. He did recover from that episode, but ultimately we had to meet with a cardiologist who recommended that he would require an implanted pacemaker in order to fully recover from those two conditions. He couldn't get on the operating schedule immediately, and so Dad was discharged from the hospital with an external defibrillating vest. And upon his arrival at home, what he discovered was that the vest was made of a semi-rigid material that made it difficult for him to breathe. He couldn't eat because it expanded his belly and made it more difficult for him to breathe. He could only sit up. He wasn't comfortable lying down. And it spent a lot of time trying to get in and out of chairs with some difficulty because of the vest. Ultimately, it did shock him, and that was painful enough that Dad took off the vest, refused to put it on again. He did make it to the operating room, received the pacemaker, but it did not benefit him. What we learned as a family is that we didn't really have a resource to make his cardiologist aware that the vest was so uncomfortable that it caused Dad to take the device off. And we also found that we didn't have a great mechanism to ensure that any feedback would ever ended up going back to the company. About 3 years after Dad passed, we discovered that Harvard had published a study indicated that the biggest problem with the vests was patient noncompliance. So as the story about my father demonstrates, healthcare is very personal. Like me, I'm sure that nearly all of you have pursued a career in the medical device and healthcare industry because of your desire to help others, to help ensure that patients can count on getting the best care available in a reliable and timely fashion and delivered by clinicians that are both knowledgeable and willing to engage in dialogue with their patients. To me, this effort is about helping clinicians answer one of the very hardest questions patients bring to the table, and that is this safe? And we all know that in the vast majority of cases, the answer is yes. However, the number and complexity of medical devices we use to treat patients has grown rapidly in recent years. And we're still challenged by a variety of issues that have an impact on patient safety. For example, in 2019, 50 medical devices were recalled in comparison to 32 in both 2018 and 2017. The number of devices being recalled is increasing, potentially due to the increasing nature of software utilization in devices. This corresponds to 55 to 90 million device units recalled per quarter. In addition, the answer to safety questions is additionally complicated by over 83,000 deaths and 1.7 million injuries that are suspected of being linked to medical devices, as reported to the FDA between 2008 and 2018. And about half of the 2 million healthcare-associated infections that occur each year can be attributed to indwelling medical devices. The problem with the transmission of infection via non-implantable, reusable instruments is also well demonstrated by the well-documented issues associated with duodenoscopes. When we look across the medical device ecosystem, manufacturers, providers, payers, FDA, and so forth, each of us has an opportunity to affect patient safety. However, our information sets remain siloed, and we don't presently have access to the information needed or an environment where we can work collaboratively to address these challenges. For example, manufacturers fear sharing sensitive information for fear of losing competitive advantage or, even worse, punitive action. Providers have the same set of fears related to business intelligence and risk of liability. Providers also have insufficient channels to share clinical experiences and provide feedback to manufacturers on device improvements. The FDA itself collects post-market data, but this is not predictive of patient safety issues and the real-world performance of devices, not to be confused with real-world evidence, which is clinical data per my good colleague, Ann Ferreter. FDA and the medical device industry wanted to address these issues and took the first step by sponsoring the Case for Quality, bringing government and industry together to enhance product quality through increased engagement and collaboration. Through Case for Quality, the FDA has worked toward a better engagement model with industry stakeholders, leading to the Voluntary Improvement Program. Thanks to the success of VIP, a new opportunity now arises to provide further collaboration between government and industry. I think we can all agree that we want to improve both the quality of medical devices and healthcare outcomes. And we can build on the foundation of trust established through VIP to do so. How? By continuing to extrapolate approaches taken in other high complexity ecosystems. We can learn from successful collaboration in aviation, general transportation, and in the prevention of tax fraud, where sensitive data is shared in order to reveal systemic risks and with the assurance of non-attribution and protection from punitive actions. Imagine the possibilities that will be realized when we are able to establish a similar partnership framework that enables us to share sensitive data across the entire healthcare ecosystem. The solution that we are developing, based on learnings from these other collaborations, is called Medical Device Information Analysis and Sharing, or MDIAS. This is our opportunity to ensure that future clinicians can answer the safety question with a definitive yes. I'll now turn the virtual podium over to my colleague, Mike McCarthy.
Thank you, Dr. Ruhlen. As Dr. Ruhlen just mentioned, Case for Quality has created a collaborative space within the medical device ecosystem. MDIAS seeks to expand on the possibilities offered by this collaborative space for the first time, allow participants to share private data to support new and existing analyses of public data sets, yielding insights to improve patient care, safety, and outcomes. In addition to Dr. Ruhlen, I'm working with more than a dozen other colleagues representing different medical device manufacturers, the FDA, healthcare providers, and other Case for Quality stakeholders to co-create and operationalize MDIAS. As MDIAS matures, we envision the group of participants expanding to also include patient organizations, payers, and academia. Given the focus on data sharing, MDIAS is enabled by an independent, trusted third party, the MITRE Corporation, who is responsible for facilitating the development of MDIAS with the stakeholder community, performing objective analysis of the data provided, generating aggregate results for the partners, and safeguarding MDIAS data. MITRE brings a wealth of experience from standing up data sharing partnerships in the automotive and aviation industries, as well as working with the federal government to address tax fraud. MITRE's analytical expertise combined with the data provided by partners, will help us uncover the needle in the haystack and the insights which can enable us to solve some of the challenges facing our industry, regardless of the role we play. We envision MDIAS performing different types of analysis to turn data into actionable information. This can include baselines, reports, as well as visualizations. These aggregate results will be de-identified to protect the partners, but we will also share member-specific results to individual partners to ensure that none of the insights are lost. Some of the examples of data sets and possibilities MDIAS has been looking at include analyzing reportable events to understand the criteria of individual MDRs, which could be predictive of future recalls, and also developing baselines to establish performance indicators for different partners within the ecosystem. We're also considering looking at device and process controls to understand from both a regulatory and industry perspective which practices are most effective at delivering safe and effective products to the field. Long term, looking across the entire ecosystem, this type of analysis could allow us to understand all of the interaction points from a patient's admission to a hospital to discharge, hopefully uncovering the insights that could eliminate post-operative infection or hospital-acquired infection across the country. These are all research areas where the sharing of private data creates the opportunity to understand issues and challenges at a level of detail that cannot be accomplished by a single entity, and generate holistic, actionable insights to improve patient safety and device quality. All of us are stakeholders in ensuring that our patients and customers receive safe and effective care. MDIAS brings our diverse ecosystem together, sharing perspectives, data, and voices that individual stakeholders often do not have visibility to. By collaborating, sharing our insights and our data, we hope to usher in a new era for the medical devices community. This new era could be one where we have access to real-time analysis and metrics, showing how our devices and treatments are used in a dynamic and evolving environment. This can be one where we can predict and solve problems before they cause patient harm. We can only achieve these goals with your participation and willingness to share data. I hope you are all as excited about these possibilities as I am. I'll now turn it over to Al Crouse to talk about our progress to date.
Thanks, Mike. We've done a great job, I think, of Dr. Ruhlen setting up for us what the reason and rationale for MDIAS is. And Mike's done a good job of explaining sort of where we're at and what it's about. Now I get the pleasure of talking to you about exactly what we've done so far. MDIAS development started in earnest last fall with forming some different working groups to get things kicked off. We're proud of what we've accomplished so far and excited to tell you about where we're headed. Our initial focus last fall was to look at the future vision of MDIAS and talk about how we could turn this vision into a reality. This last spring, we identified a proof of concept that would help us to define how we work collaboratively on testing how this partnership between FDA, industry, and the providers would work, and if it would impact product quality and patient safety. To do this, we needed to work hard on how we're going to build a trusting relationship among these different stakeholders and identify data protections that would be in place to assure that we maintain that. As Joe Sapiente talked about at the outset, there's been a lot of background work done that started to build that trust, but we're working to build that further and actually get people beyond that initial stage of talking and into sharing data. To do this, we've identified the trusted third party of MITRE, who's helped us set up and start working with the MDIAS system. And we're now focusing on getting tangible results out of MDIAS and demonstrating the values that Dr. Ruhlen talked about earlier. To do this, we're developing a set of use cases. And these are very specific cases that will identify a goal that we have in mind and a problem that exists, and identifying, gathering, and analyzing data, and then working on also presenting results and findings of those data analysis to the entire MDIAS organization to hopefully help solve the problems that we've been talking about. To do this, initially, we wanted to start with public data, and we're working with FDA to use the publicly data available that they have, and then look at, as we define that analysis and identify areas where maybe that data is lacking, we could then help work with maybe some of the industry partners to identify additional data they may have available that could then supplement that, again, being de-identified, and then expand out on that to do a better job of solving these problems. To do this, we have some very specific steps in mind that will identify how we're using these data and also how we're making sure we have the right protection requirements in place to give industry partners and provider partners confidence in sharing that data. To start this out, we're identifying a MDIAS program charter that will define overall what the system is and how it works. And then we're also defining a data management plan. This data management plan will be very specific about how we're going about gathering data, bringing it in, de-identifying it if need be, if it's not already de-identified before providing it to MDIAS, and then how we go about analyzing and working with that and what information we're going to share out of that. And ultimately, we will also work on cooperative agreements, the sort of contractual non-disclosure items that would make people more confident in sharing the data with MDIAS. So to do this, we're working on all of these different aspects, and our expectation is that in 2021, we will be able to review the results of these initial proof of concept activities and determine the next steps in maturing and operationalizing the MDIAS system. So if you're interested in participating in this project, there's still lots of available time and effort needed to get going on this. Feel free to contact us at the caseforquality@miter.org, as you see across the bottom of your screen. We'll now turn it back over to a panel discussion. Thank you.
Thank you very much for those outstanding and informative presentations. Now we have a few questions for the panel members. Our first question is, with the uncertainty around COVID-19 travel restrictions, what is the plan to support virtual appraisals beyond 2020?
For now, we are considering virtual options as long as it is necessary. We are also considering how and when these will be applicable and continuing to collect lessons learned. One other thing is that we're also considering how we might use a mixed approach, wherein we might do some activities on site and some virtually, where that makes sense. And we'll continue to see how we can do on site if that's possible and what safety precautions make sense. We'll also have a virtual training made available to all of our appraisers to train them on those guidelines for how we can continue to conduct these remotely. Thank you.
Thank you, Kim. Our next question is, how will alignment with the Case for Quality collaborative community affect VIP?
So Alan, the timing for the transition to collaborative community is actually very good for the VIP transition from pilot to program. As Joe mentioned at the outset, the Case for Quality was really started with collaboration in mind, and the structure of the VIP was set up with a similar context. So we can actually adjust, and as we complete all the supporting documents and the planning for transition to a formal program at the end of this year, we're able to make those adjustments and reflect the change to the collaborative community. So really it'll be alignment with what the intention was and how the program was set up and structured. and it shouldn't mean really any change or difference in terms of how the program is executed and rolled out and how appraisals are conducted. So it's really a minimal change at this point.
Thank you, Rob. That's very helpful. To give everyone an idea of timing, what are the milestones and timelines to transition VIP from a pilot to full program?
There is a few activities that are going on, and a lot of the work that's going on externally is moving and progressing well. So there is obviously the work that's being done by the collaborative community, the VIP governing committee as a whole, to operationalize and set up the structure for that existing program. And then on our end, from an agency standpoint, there is the development of a guidance or policy around that, announcing here's the program, here's how the agency interacts with that. That's the gate right now that we're working towards, because part of that process obviously goes through its internal clearance activities, its review. It will go out for comment so we can get feedback on it, how we interact, and go from there. So there is several activities that need to happen and gates that go along the way: internal review and clearance, the agency's review and clearance. We may actually need to go up all the way to the department in order to get that reviewed and cleared. So we've been working that background process with the same target as the operational program development and its goals. Obviously, taking into account COVID and a lot of the work that's happening behind the scenes, a lot of the effort that's been really geared towards helping move more guidances, more emergency use authorizations along the way, that's distracting from the same resources. But we are still committed to trying to keep it moving. So the goal is, at this point in time, early calendar year 21, I got to remember the FY and the regular years, to get that announcement out, get that draft published, and open it up for comments and feedback.
Thank you very much, Cisco. That was very helpful. Lastly, I'd like to ask Dr. Ruhlen, Mike, and Al, why is MDIAS important to your organization?
Well, I'll start with that. That's a multi-level response from our perspective. The first, and I'll just try to touch on a couple of these things, but the first one is obviously there's an opportunity to have even greater improvement in reliability in medical devices themselves. But the opportunity for us to participate in this program means that we can be better providers of care. We will better understand potential issues that can arise with the use of medical devices. We can hopefully learn how to better predict events in a patient's future that might be harmful to them, or that at least might mean that a product is nearing the end of its life cycle and will need some additional attention. And finally, for patient engagement issues, the opportunity for us to better explain the risk benefits of the use of technology and devices will be an extraordinary addition in terms of helping engage our patients and help them feel comfortable with their safety.
So building on what Dr. Ruhlen said, obviously within the medical devices industry, patient safety is first and foremost our priority. And we view MDIAS as an opportunity to hear voices and perspectives that we don't normally have visibility to, as well as collaborating on different data sets to hopefully unlock the key to building better devices with smarter controls, with better processes, enabling the best possible treatments for our patients. This really furthers Baxter's mission of saving and sustaining lives, while also raising the bar for quality and safety across the industry as a whole. And we're really excited to be a part of it.
And to add on to what Mike said, as a member of the team that's working from a small manufacturer perspective, I think there's also a number of things that we can take away from this. First off, most small medical device manufacturers are working on somewhat derivative products of other products that exist out in industry. And so if we can learn what problems there are with these existing similar products and address those before we get out on the market or into clinical studies, be very helpful to make sure we don't have those sorts of issues. Certainly one of the easiest ways you can go out of business as a small company is to have a significant quality issue with your product. And then I'd also like to say, you know, we have very limited resources in small companies. And so one of the abilities potentially of this system would be to provide data into the system and have some additional resource help in looking at significant problems with similar types of devices and getting some additional data analysis resourcing to help address what should be some of your main concerns and what should you be working on. So that's pretty much it from the small manufacturer perspective. Thanks.
That's wonderful. Thank you very much. I think that is a very salient point to conclude on here today. On behalf of myself and MDIC, I thank you all for your participation on this wonderful panel. This has been a very helpful highlight of the transition of the Case for Quality to a collaborative community, the outstanding progress of the Voluntary Improvement Program, and the effort to stand up the exciting new initiative, MDIAS. And on that note, thank you again. I hope everyone has a wonderful day, and please tune in to the remaining MDIC annual public forums.
Thank you for attending MDIC's annual public forum. We hope you will join us for next week's session on external evidence methods for regulatory decision-making. Visit apf.mdic.org for more information and to catch up on previous sessions.